Thank you very much. You can hear me okay, correct?
Yeah, you're good.
So let me share my screen. Is that visible to everybody?
Yeah, that's good.
All right, great. Well, thank you very much for the invitation to speak. So I'm a radiation oncologist, and I work at NYU. I'm the director of research in the Long Island School of Medicine Radiation Oncology Department, and also the medical director at the Cyberknife Manhattan facility. Aaron reached out to us a few months ago and thought it would be helpful and interesting for us to walk through some background on the type of radiation that we use at our facility. And so this is going to be a kind of a broad lecture that talks about what radiation is and how it works, and how we kind of integrate that into the rest of oncology care. And then specifically the type of machine that we use, which is unique in its delivery and kind of how it works. And so we'll go through some of the neat technical aspects of that. So, starting off with what radiation is, when we think about cancer care in the modern era, there are kind of three main areas, three kind of specialties that are integrated together and help deliver treatment. And every cancer and every stage may interact with each one of these three specialties, and those are radiation oncology, which is what I specialize in. The second would be surgical oncology, and that is going to be dependent on the type of cancer you're dealing with. So, for example, if you're dealing with a lung cancer, you might meet a cardiothoracic surgeon. If it's a prostate cancer, you would be dealing with a urologist. So each surgical specialty kind of has their own division that deals with oncology. And then the third group of physicians that helps treat cancer are called medical oncologists. And these are doctors that really specialize in delivering drug therapy or systemic therapy. And that can be a variety of things, from what we know about with like chemotherapy, to oral therapies, which are sometimes kind of targeted to certain types of cancers. And then lastly, immunotherapy, which I think a lot of us have heard a lot about recently in the last 5 to 10 years. This has become more and more ubiquitous. So let's kind of focus in on talk about radiation, which is what we deliver here and how it kind of works in the spectrum of treatments that we have. So a lot of people think of this this is the type of radiation that we deliver. This old James Bond thing where they're kind of using radiation as kind of a scare tactic, but it's definitely come a long way from where it was and what we thought about its utility maybe 50 to 60 years ago. And going all the way back to the very beginning of the discovery of the X-ray is really where we see the roots of radiation oncology. So the X-ray was actually discovered by a German, William Röntgen, back in the late 1800s. And this was really a massive achievement, because at that time there was a ton of scientific revolution that was going on, and this was kind of part of that, where William Röntgen discovered this X-ray, and within a few years we were utilizing it clinically and using it for a variety of different things, both medically and otherwise. And so this is where we find the roots of radiation oncology. If you fast forward 15, 20 years after the discovery of the X-ray, this was the type of facility that you might see at a hospital or at an academic center that was delivering radiation. So obviously kind of looks fairly primitive. There's a lot of kind of machinery and various pieces of equipment attached to what is a patient bed. And so this is what we were dealing with shortly after the discovery of the X-ray. And you fast forward over 100 years later, things have really come a long way. And this is a kind of a picture of an inside view of a radiation facility. Right here in the middle is that same bed that you saw here in the prior photo. And this is really where a patient will lie down. And then this top of the picture here is where the radiation kind of comes out of. The whole thing actually can rotate around the patient and come in from a variety of different angles. So you can kind of see just from this picture how much change has happened over the last century. um, in the mid 50s and 60s was really when we started to understand how to integrate radiation oncology into cancer care. And a physician out in California at Stanford, Dr. Henry Kaplan, was one of the main pioneers of our field. And he, in fact, was the first one to cure Hodgkin's lymphoma with radiation. And so this was a really massive achievement. And to kind of give you an idea, at the same time, a lot of the chemotherapies that we currently use or did use to treat things like leukemias, particularly in kids, were being developed up in Boston by Cindy Farber. So a lot was happening in the 50s and 60s, and radiation oncology was part of that, and actually was the first type of treatment that was able to cure Hodgkin's lymphoma. So there are a couple of different aspects to radiation oncology that are interesting from like a scientific standpoint. You know, a common question I get is how do I just lie on a table and get radiation delivered inside my body and have a tumor basically disappear and achieve essentially the same outcome as a surgery. Well, the way it works, and this is kind of a generalized view of an X-ray. We're looking on a graph here with depth on the x-axis and radiation dose on the y-axis. And essentially what this is showing is that when an X-ray goes through matter or goes through a patient's body, it will gradually deposit increasing dose until it gets to kind of its peak here. And this peak is basically going to be dependent on the energy of the X-ray that you're using. And so one of the really fascinating things to radiation oncology is that you can spare the skin, so you don't have to open up the skin and go in like you would with surgery, where you're cutting through different tissues to try to get to where the tumor is. But the X-ray actually does that on its own just because of the pure physics of it. And so when you're delivering radiation treatment to a tumor, you're kind of having all these beams converge onto a certain area in a patient's body. Kind of an analogy that I use would be, imagine you're kind of going out in the middle of the night with no light whatsoever, and you have maybe 150 people holding flashlights, and they're all shining the flashlight on the same spot on the ground. Well, that area on the ground is going to be very, very bright, but the surrounding area is not going to be that visible. It's going to be a lot darker. And it's the same idea with radiation. When you're kind of imagine those flashlights are actually just different angles that the radiation is coming in as it comes out of the treatment machine, and as it kind of lands into the tumor. That's how we're able to deliver that radiation dose and spare the rest of the surrounding normal structures. So that's the physics behind how this all works. So what about the biology? Well, once you get the radiation into the tumor, a lot is going on at that point. And essentially what you're seeing, and this is, you know, our historical perspective on the relationship between the X-ray and DNA, but there's actually a lot more that we're beginning to understand about the vasculature and other microenvironment changes that happen when you deliver radiation. But one of the fundamental reasons why X-rays can kill cancer is that these cells are really they're behaving erratically. They're cells that have kind of gone awry and keep dividing. And part of the reason for that is that their DNA is damaged. What the X-rays will actually do is will inflict additional damage into the DNA of these cancer cells. And because these cells are already so damaged, they're not really able to repair that. And so when they try to divide again, they will subsequently die. It's something that we call post-mitotic cell death, and it's really one of the primary mechanisms that radiation will kill tumors, and preferentially spare normal tissue where the regular cell will have the DNA machinery to be able to repair a lot of the damage that can be inflicted by an X-ray. So that's the biology of how radiation can essentially deliver a curative dose that mimics what you could find with surgery in a lot of cases. Now, you might, if you have any experience with radiation, you'll come to understand that certain types of radiation treatments are delivered over a series of fractions or treatment fractions or days. And this could be anywhere from a single treatment all the way up to over 9 weeks of treatment. And so the concept of separating out those doses really, it kind of grew out of this idea of trying to spare regular tissues that are surrounding a tumor. And that's how we were able to kind of cure a lot of patients early on in the development of radiation oncology. But as time has gone on, because we've been so much better at sculpting dose just to where the tumor is going, which we'll get to in a second when we talk about Cyberknife equipment, we're really able to minimize the halo of radiation that's going to surrounding normal structures. And because of that, we've seen our ability to take some of these really long treatment courses, which, like I said, could be up to 9 weeks of treatment, and really bring those down, sometimes all the way to a single treatment. And so the concept of fractionation really grew out of our hope to minimize side effects. But as we've gotten better with imaging and equipment and treatment delivery, we've really been able to bring those number of fractions down. So there's a lot of different types of radiation you might read about. I think the easiest way to break these down is to separate them into internal radiation and external radiation. And internal radiation is something that you might have heard the term brachytherapy used in the past. And what this is also known colloquially as seeds. But brachytherapy is basically putting a radioactive source into a patient's body. And it's a common thing that we do for prostate cancer and also different gynecological malignancies. But this is really something that was used quite commonly and is still used to this day for certain accessible tumors, like in the pelvis. Probably the most common way that we treat different cancers throughout the body is using external radiation, where a patient, rather than having a source implanted into the body for a period of time under general anesthesia, external radiation will just have you lie on what we call a treatment couch or a treatment bed, and then the machine will move over your body. You won't see anything or feel anything. There's no cutting pain or anesthesia. You'll just lie there for probably anywhere from a few minutes to 30 minutes or a little bit more sometimes. And the treatment is kind of delivered to where the tumor is. And there's three main types of external radiation. One is called intensity modulated radiation therapy. This has been around for a while, and it's a very commonly used type of treatment. But this is one that kind of requires additional treatments. This is one that employs the use of fractionation, or separating out those doses for a longer period of time. Proton therapy is different in that it's not actually using X-rays; it's using protons. And protons are different in that they actually have a mass that you have to deal with, and because they are heavy particles, that it takes a really expensive and complicated system to accelerate those protons, because they're actually heavy, unlike an X-ray. And so the facilities that are able to do this are very limited. There's usually only a few in certain geographic locations, but they're very commonly utilized for pediatric cases, or kids that have different tumors, CNS tumors, or brain and spine tumors. And then the last one is one that I specialize in, which is stereotactic body radiation therapy. And essentially, and this is something that can be delivered by using a Cyberknife platform. And this is essentially something that is delivering radiation doses that are very targeted and precise, with a very tight radiation cloud, and they are delivered over a very short period of time. So, for example, there is some types of prostate cancer or lung cancers that used to be treated with between 30 and 45 treatment fractions delivered daily over a period of weeks. We've actually been able to bring those down all the way to 5 treatment fractions using these advanced types of machines. And so that's kind of one of the fundamental aspects that's different about SBRT with the other types of radiation. So I already kind of talked about brachytherapy a little bit here. This is kind of just what it looks like if you're delivering radiation for prostate cancer, where the tool actually has to go into the patient's body, and then the radioactive sources are placed into the organ that has the cancer. And this kind of gives you an idea that this is an X-ray. And you can see here all these tiny little seeds that are maybe less than the size of a grain of rice. all in the prostate for a type of treatment. So there's a lot of pros and there's pros and cons for each radiation type, and that's what a radiation oncologist is really there to help you understand, like what type of radiation would be beneficial for you. So pros for brachytherapy is it's a very quick treatment. Similar to SBRT, it's not going to require many weeks of you coming in. And it has excellent control outcomes and side effect outcomes. But it is more invasive and it does require oftentimes general anesthesia. And it oftentimes can't be used for all types of cancers. It's not something that's commonly used for example, like a lung cancer. So this is something that's a little bit limited in scope. It could be a little bit more invasive. And you also have to be careful when you're getting brachytherapy when you're around certain individuals like kids and pregnant women. Moving on into external beam radiation, this is an example of a plan. It's called the IMRT. This is the longer course of radiation that we talked about. You can see that this is actually a CT scan with a radiation plan that's superimposed onto it. And in this case, it's treating a prostate cancer, which is that red area right in the middle of the scan. And you can see that there's 5 different beams that are kind of coming in and all converging right on that organ, and that's what you're doing to kind of achieve a type of a dose of radiation that can get rid of the cancer. Now, this is something that's delivered with linear accelerators. This is another example of where the patient will lie down, and then this is where the machine will rotate over your body, and this is how the X-rays will come out, actually be delivered to the tumor. Now you can see here, the inside of one of these machines is obviously very complicated. You can see right at the treatment head here that there's these little mechanical leaves, and they can actually sculpt different shapes. And so the X-rays can come out and they can be very well sculpted so that you can maximize the dose that goes to the tumor and minimize the dose that goes to the surrounding normal structures. So big pros here for IMRT. It's not invasive. You don't need to go into the OR. Manageable toxicity, very good control outcomes for different cancers. But it's not quite as precise as other types of radiation, oftentimes, and often it will require longer courses of treatment. Now, we also talked about proton therapy. Protons, this is a similar graph that I showed before, where it shows the depth in a tissue and dose, and it's comparing X-rays with protons. And one of the big advantages to protons is that when the protons get to where the tumor is, they basically stop and they don't go any further. And so that's why you can see differences in radiation dose distribution. And this is why it's so beneficial when you're using it to treat kids with cancers, because you're really trying to minimize even low doses of radiation to normal structures. So again, non-invasive, this is external, so you don't need your, you don't often need anesthesia, good control and toxicity outcomes, and it reduces the overall integral dose of radiation that a patient sees. But there are limited numbers of these centers throughout the country. Oftentimes these are kind of expensive types of treatments because of that. They can be a little bit longer or quite a bit longer than their comparative shorter courses of treatment. And so lastly, focusing on what I have the most experience with, which is SBRT, or stereotactic body radiation therapy, a machine that delivers this type of treatment is called Cyberknife. You can see that all those little lines there are representing radiation beamlets that are coming in, kind of falling into the target tumor there that's right in the middle. And what's interesting about this is you kind of takes that example that we saw with IMRT, where there were like 5 large beams, and it takes it kind of to an extreme where there are up to sometimes hundreds of beams that are coming in and kind of converging. And what that allows you to achieve is a very specific, precise, conformal radiation cloud, very tight halo radiation, right to where you want to treat where the tumor is. So there's a lot of aspects to this that are important. It has to be you have to use image guidance when you're delivering this treatment, so you actually have to confirm where you're treating during treatment. You have pretty complicated treatment planning software, so a physicist will actually help create these radiation plans, and oftentimes the accuracy is on the order of millimeters, particularly if you're treating in the brain or the spine. It achieves a very conformal, which basically just means kind of the radiation cloud is very tight and right around the target. And you're able to deliver a big dose of radiation over a short period of time and achieve what we call ablative radiation treatment. So we kind of already walked through this, so we'll skip the slide. So now we're going to talk a little bit more specifically about the Cyberknife platform. Before I go here, are there any questions that you guys have that you wanted to ask about what we covered so far? Okay, so Cyberknife. So Cyberknife is a pretty neat machine that was actually developed out in California at Stanford several decades ago. And the machine was developed by a neurosurgeon out at Stanford who had a lot of experience using big doses of radiation delivered in a different type of radiation machine called a gamma knife. And he thought, well, we can use gamma knife to treat things in the brain, but it actually can't treat things outside of the brain. It can't treat in the chest or the pelvis or elsewhere. And he thought it would be really neat if you could take that concept of delivering big doses of very precise radiation to tumors in the brain and kind of take it all the way out to other sites. And it really was a game changer during the late 90s and early 2000s. So what the basic concept here is, we took a linear accelerator, which is what I showed you before, delivers external radiation with this linear accelerator and this machine that kind of rotates around a patient's body and has these little leaves that kind of sculpt the dose. Well, it takes this linear accelerator and it actually mounts it right onto one of these really fancy $1 million robots that you might see build different equipment out in Detroit. These things kind of build all sorts of things. They build cars. They're used for a variety of really complicated processes. But this is essentially what you did. And so you put this on top of the end of this robotic arm, and you're able to come in from a variety of different angles and deliver radiation in a very precise arrangement of beams. So you basically can deliver a lot of different small beams at different angles coming in from essentially what we call, non-coplanar, basically means they can come in from a variety of different angles and really all converge on that one spot within the patient's body, and to minimize radiation exposure to the rest of the surrounding structures and maximize radiation to the tumor. So as I said, these can be sometimes hundreds of different beams, individual beams coming in and converging on a certain area from a variety of different angles. And this is the plan itself is something that is kind of developed by very sophisticated planning software before a patient will come in for treatment. It does take some time, and I work with a physicist to kind of help create these radiation plans and make sure that we know the proper beam arrangement or beam angles that these X-rays are going to come in at. So this is a breakdown of what it looks like if you walked into the room here at the Cyberknife Center. And to give you an idea and walk you through what each of these things is used for, the patient would lie down here on this table. Usually this is totally flat. It's actually coming out of a robotic arm, and this is a pretty complicated type of, we call it treatment couch, where a patient will lie down. But this thing can basically move in all sorts of angles and position a patient so that they can be perfectly aligned with where we want that radiation beam to come in at. So that's where the patient would lie down. You can see over here, this is the actual cybernetic machine. So you can kind of imagine that robotic arm that I showed you being right here. And then at the very end, this is the linear accelerator where the X-rays are actually generated and then delivered. Now, another really cool aspect to this equipment is that on the top here, you can see that there's these X-ray, regular diagnostic X-rays that are coming out. And then the floor panels here are receiving these X-rays. And what these X-rays are actually doing is they're going through and checking the position of where the tumor is. And so while somebody is getting treatment, the machine is actually constantly checking and detecting where the tumor is at in real time. And I guess, one question is, how does it do that? Well, oftentimes, depending on the cancer site, for example, like a lung tumor, if it's a early stage lung cancer and it's something that is being treated with radiation, we can actually put in these little gold markers into the prostate. Now, these are different from markers that I talked to you about before, which were brachytherapy seeds, which were radioactive. These markers are actually just little gold seeds that are very small. They're placed into the tumor, and that can be placed by an interventional pulmonologist, oftentimes the same way that these tumors are biopsied. And so those markers will go in, maybe 1, 2, 3, or 4 markers will go in right around where the tumor is or inside of the tumor itself. And then the X-ray will kind of see where those markers are because they're really bright on an X-ray, and monitor where they are in real time. Now, using lung cancer as an example, what's really cool about the machine we use here is, in addition to tracking where those markers are in real time, it actually can monitor the breathing pattern of the patient. And so a patient can kind of lie there and breathe normally. And as they're breathing, this piece of equipment over here is going to actually monitor how the breathing is shaped. It'll create this breathing pattern that can actually be mimicked by the machine itself, and then interrogated and verified with these X-rays to detect where the fiducials are. So it's a pretty advanced way to monitor where the tumor is, even in the case where the tumor is moving with respiration. So it's a pretty advanced way to go about doing it. And so this is just kind of giving you an idea of how accurate a tumor like this would be treated when we're using accuracy. There's a variety of different publications that have kind of looked at how accurate this platform is using the aforementioned ways of monitoring motion, et cetera. And they've seen that this accuracy can be, oftentimes sub-millimeter, particularly, when you're treating things that are stationary, like in the brain or spine. And then, the accuracy can be extended into other types of cancer sites. For instance, when you're treating prostate cancer, it can be essentially on the order of 1 millimeter of accuracy or so in those treatments. And this is important because, you can often see movement during a course of treatment. So, for example, if you're in the room and you cough, or you move your body a little bit because you have an itch, or you're trying to reposition generally, or there's a lot of motion inside of our own bodies that we can't control. Respiratory motion is the obvious one, but also your organs are kind of always moving around, especially in your gut. They're kind of drifting to new positions as you're kind of metabolizing food, and you're filling up your bladder with urine, or you have a variety of things that can kind of create motion within your own body that aren't controllable. So that's why it's so important to be able to monitor where your target tumor is during treatment. And the reason why it's so important for SBRT is that you are delivering those big doses of treatment, radiation doses, over a very short period of time. Now, these are just some kind of cool publications that have shown how accurate it can be in tracking these tumors and how they actually move over time. So kind of walking through what it would look like to undergo Cyberknife treatment. And to some extent, this can be extrapolated to a variety of different radiation modalities. But the first step is really a consultation. And so you would come in and you would meet me, and we would talk about the problem we're dealing with, which could be any number of cancers, from prostate to brain or lung cancer, whatever it is. Sometimes it's not even cancer. We use this sometimes to treat other things as well. But a consultation really to walk through what the process looks like, the side effects, and how effective this can be, and what the data for it is. This is an example of placing fiducials. So if it's prostate cancer, we would put fiducials into the prostate. If it's a lung cancer, I would have an additional pulmonologist see the patient, and they would put in the markers. In some cases, you don't even need markers. For instance, if it's a tumor in the brain or the spine, you actually don't need to put any markers into the tumor, because the brain and spine are so stationary, and the bones in that area are kind of constantly monitored by the machine, so that you don't actually need the fiducials. The bones kind of act as the fiducials. All right, so the next step is actually, once the fiducial markers will go in, we'll get what we call a planning scan or a treatment planning scan. And this is at the very least a CT scan, but can also include other types of images like an MRI or a PET scan. These are all images that we try to obtain to help the radiation oncologist identify where the tumor is and also identify where the normal organs that are critical that are nearby are. And we do these scans in the position that a patient would be treated. That's why we call it a treatment planning scan. And so, depending on the location of the cancer, you might be positioned in certain ways that are comfortable, that are reproducible, that can identify the location of the tumor easily, and so that those radiation beams can actually come in optimally. And so for like a prostate case, you might use kind of a position like this and use this thing called a Vaclock bag, which is essentially a personalized bean bag that kind of molds to the anatomy of the body and make sure that at day to day the setup is correct. For a breast cancer, you might have the arm above the shoulder and kind of getting more space so that you can treat the breast tumor. And then for something like a brain tumor or something up in the head and neck region, we actually create this mask that goes over the whole head and immobilizes in that way. It's all custom so that it's comfortable and it's reproducible. So it does take time to create a radiation plan. You can imagine this is a pretty complicated process, and usually it takes a couple of weeks to create a plan because these are all really personalized. So you kind of think of this as doing surgery. You want to make sure that you're hitting the tumor. You want to identify the tumor properly, and you need to identify all the adjacent critical structures so that you can make sure radiation doesn't go to those areas. And doing that involves a lot of people. The radiation oncologist will actually create the drawing using an SCT, maybe an MRI, maybe a PET scan to really iron out where we want to treat. And then another couple of specialists get involved, usually a dosimetrist and a physicist that help create a radiation plan using a sophisticated computer algorithms that allow a particular beam arrangement and dose distribution such that all of the areas that I want them to hit with the radiation are covered, and the areas I want them to avoid are avoided. And so that does take some time, but it's all a personalized process. And once it's actually completed, that's when the patient will come in. And so this kind of gives you an idea of what a physician is doing. We're kind of identifying the organs and the target that we're trying to hit. So we're both contouring the cancer target, and we're also contouring the normal structures that we know from a lot of research can be sensitive to radiation. So using prostate cancer as an example, we'll be getting a CT and an MRI, and then we identify normal organs like the bladder, the urethra, the bones, the bowel, the rectum. But in addition, we'll find the targets, which are going to be the prostate and sometimes the lymph nodes. And so we try to optimize radiation to go to the cancer and minimize radiation going here. We use some sophisticated planning software to help create a plan. So this gives you a little bit of an idea of what it looks like while you're creating a plan. And the different colored lines here are actually giving you ideas of the different radiation doses. And so we call it the prescription dose, or the dose that you need to kill the tumor, is this orange line here. And you can see that it's a line that encompasses all of the prostate in this case, and then minimizes all the adjacent bones, soft tissue, and rectum, and in this case, the bladder from the side. So it does this by having all these different beams kind of come in at different angles and avoid the structures we want to avoid it. This is the type of plan that a radiation oncologist is reviewing and that a physicist is creating. There's all sorts of quality assurance that is done on a platform like this. We have physicists and dosimetrists and radiation therapists constantly monitor these machines every day. There's machine checks, triple checks. The plans oftentimes delivered on a fake patient here. You can see here, this is a physicist setting up what we call a phantom, which is essentially acting like a fake patient where the beam is delivered, and then you actually measure how that beam was delivered, the radiation dose was delivered, make sure that you're delivering it the exact same way that you planned it. And so there's a lot of quality assurance that it takes place before a patient will get into the room and actually get the treatments. You can see a lot of different machines are used, different water phantoms and calculations that are done before anybody goes into the room. So a lot of safety is performed. You can see this is another way to look at all the different checks and safety checks before the patient will even get on the treatment. All right, so let me stop there since we have a little time at the end and answer any questions that you guys have about Cyberknife and radiation oncology and kind of how it fits into the treatment of cancers. Does anybody have any questions?
Yeah, I had gamma knife surgery for a brain tumor, stage 4, which really shrunk the tumors a lot. But I have also in my lungs, I have lung cancer metastasized to the brain. So my doctor hasn't said anything about having Cyberknife surgery for the lungs. But I'm taking a pill medication that controls it. It's been staying stable.
That's
to
great.
test trial.
So you probably know a lot about what we just talked about. I mean, gamma knife was actually the thing that was invented before Cyberknife to do the type of treatment that you actually had, and it worked really well for things that are kind of above like the chin here.
Yeah.
Cyberknife was the thing that was really developed, you know, for both, you know, things in the head, but also things below the head. And it's become you know, pretty standard to do in a variety of sites. For lung cancers, we've gotten really good at using targeted therapy like it sounds like you're on.
Yeah.
So we've realized that the DNA of these cancer cells can be you know, targeted and disrupted and stopped with an oral pill, which is amazing.
Yeah.
It's progressively better at using these types of drugs. So I'm glad you're having a great outcome.
Thank you.
Any other questions? All right. Well, thank you, Aaron. I'm not sure if you're still on, but I appreciate the invitation. And if anybody has any other questions, oh, looks like we have a few here. How long does it take for a tumor to shrink after one of these treatments? Great question. So usually after we deliver a full course of radiation treatment, we don't check for a period of time. And it depends on the cancer type and location and stage. But kind of as a rough guide, I'll oftentimes wait 2 to 4 months before I do any checks. And the checks really depend on the type of cancer. So if it was lung cancer, then I would get a CT scan to check the lungs. If it was a prostate cancer, I would get a blood test, a PSA. If it was a brain cancer, I would get an MRI. So it really depends on the site. And that would dictate the type of scan that you're going to get. And it's usually done every maybe 2 to 4 months after you finish. And the reason for that is that oftentimes the cancer has had the effect, but going back to the biology that I described, where the radiation has inflicted damage to the cancer DNA, sometimes you don't see that DNA damage reflected until that cell tries to divide again and then it dies. And that cell could divide again while you're getting treatment, but it could divide again months later as well. And so whenever that happens, that accumulative cell death will be reflected in a scan or a blood test. And so it does take some time to see that reflected. And that's kind of how we monitor the response to treatment. All righty. Well, thank you very much for the invitation, Aaron.
You're welcome. Thank you all. This was great. Hope everybody got something from it. We're also going to put it on YouTube.
May I ask one more question?
Sure.
If after 1 year of 1 year after the treatment and the size of the tumor hasn't shrunk, what happens then?
Well, it's a great question, and it really depends on the type of tumor, the location. So, you know, if there are some tumors that you can treat, that the goal is just to stop it from growing, and that basically indicates the cancer can't keep dividing. So, for example, there's some tumors in the brain where, let's say they're a centimeter, and you treat them with radiation. If a year later they're still a centimeter, that's okay. We just didn't want it to continue to grow. You know, other cancers are a little bit different, so it really depends on the type that you're dealing with and what you would expect, and that's why it's so important to talk to your oncologist to understand what they're expecting in those follow-up scans.
Okay, so does that mean that one has to keep doing the checkups like every few months?
Yeah, good question. Usually it does mean that. When I treat patients, I'll kind of follow them for forever. But as time goes on, you kind of spread out those checkups. So for instance, I might see somebody 4 times the first year after they get treatment, and then 4 times the next year. And then a year after that, it might be 3. And then as time goes on, we might just go to yearly checkups. And so you kind of spread things out as you go along.
Thank you.
Of course. All right. Thank you all. Have a wonderful day.
Thank you. Take care, everyone. Bye.
Thank you.